A very good evening, everybody. On behalf of NUS NUS Department of Ophthalmology, as well as the Center for Innovation and Precision Eye Health and the National University Hospital Department of Ophthalmology, it is a good evening indeed, and thank you so much for joining us today for this webinar series. We have a very distinguished speaker. We are very fortunate to have Professor Kendall Frick, and I'm going to introduce her. She is based at the Johns Hopkins Carey Business School, where she also has a joint appointment in the Department of International Health. With a PhD in Economics and Health Services Organization and Policy from the University of Michigan, she has built a distinguished career spanning nearly 3 decades at Johns Hopkins. Now, this includes 8 years as the Vice Dean for Education. She is one of the foremost health economists in the United States, with expertise in cost effectiveness and cost benefit analysis across a wide range of clinical and public health domains. And this includes not just ophthalmology, but also ENT, nursing, cancer survivorship, and global health. Her work is widely cited with over 35,000 citation and a H index of 85. She has won multiple awards in her distinguished career, including the Johns Hopkins Diversity Recognition Award, the Faculty Service and Mentoring Award, and the Penn State's Outstanding Scholar Alumnus Recognition. This is just a short form of her CV, and I'm sure, if I'm going to read the entire transcript, it will take us a long time. But really, the topic that she's going to share with us today is very timely, Professor Frick. This is, she'll be speaking about the cost effectiveness of eye care. It is timely because in Singapore, the healthcare cost is on a upward trajectory, and it is soon going to be untenable, and there is a need to, in the colloquial term, bend the cost curve. But yet, the irony is, and the challenge is not to let quality suffer, right? So that's a very tough balancing act from my perspective. So personally, I am very, very excited to hear what you have to say from the ICAS perspective. Together with me in the panel is Associate Professor Lu Xing Chi, who is the head of department in the head of Department of Ophthalmology in Alexandra Hospital. This is one of the sister institutions within our cluster. So after the talk that you're going to deliver, Professor Frick, we will have a good discussion amongst ourselves, and I'm sure if there are any questions from our audience, we will also raise those questions as well. Without further ado, Professor Frick, we are very pleased to have you with us. Please, the stage is yours.
Well, good evening, and thank you for the invitation. This is a very important topic to talk about, as you mentioned, and it's always interesting because we've certainly had the problem of needing to bend the cost curve in the United States for many, many years, and it seems like that's a problem that countries around the world are grappling with more and more in addition to what we're dealing with here in the United States. So you can see my screen?
Yes, yes, we can.
Okay, great. So this is an introduction to cost effectiveness. And really thinking about use of the tools, the different types of tools, some of the terminology for the tools if you're not familiar with it, so that you can become more able to have a discussion about what you see in the literature, to contribute to studies that are being done, and to figure out whether what's in the literature is good quality data that you should be able to use for guiding decisions, or whether additional studies really need to be done in order to make the best decisions possible. So if we start out with the question, well, what is cost effectiveness anyway? Cost effectiveness is a tool to systematically place a value on the resources used, as well as place a value on the clinical and social outcomes achieved from a medical care or public health intervention, and then make a comparison with other potential uses of those resources. And the key to using this tool, just like if you were using a tool to fix something, is to understand how the tool works, to be able to really, choose the best tool possible when there are choices of how to use the tool, and to understand how to interpret the results of this tool. So, in terms of eye care, why is it important to apply to eye care, and what are some of the complications of using the cost effectiveness tool when it comes to eye care? First of all, we're learning that the retina can tell us about the health of other body systems. There's all kinds of work going on in the United States and around the world to look at, what do those photographs of the retina tell us about cardiovascular health, about dementia possibly. And then obviously also systemic conditions can affect the eye. And so when we're looking at cost effectiveness related to vision care, how does the cost effectiveness of treating other things affect vision? And how does the cost effectiveness of keeping the eye healthy and vision unimpaired affect other things? Impairment is also challenging. Impairment for other parts of the body is often painful. Impairment in vision doesn't have to be painful. You can see I'm wearing my progressive lenses this morning. Without these, I can't even read my screen. With these, I can, but that's seriously an impairment. It's not painful impairment, but it's there. It can impact many aspects of quality of life. It can impact my ability to work. When I was younger, it would impact my ability to learn if I didn't have glasses. It could impact my ability to cook safely if I don't have glasses. So many things can be impacted in addition to simple function like, can I move around by myself? Can I safely go to work, to the store? All these other things. I mentioned the impact on work and learning, and it can also impact my family. If I can't cook, if I can't work, if I need to be taken care of by a family member, those are all very important things. In many countries, there's an inequitable distribution of providers. Even in the United States, I sit in a city that has two major academic medical centers. So there are more ophthalmologists in those two major academic medical centers, the Johns Hopkins School of Medicine and the University of Maryland School of Medicine, than probably in many countries in Africa, particularly sub-Saharan Africa, combined. But even in the United States, it's not just internationally inequitably distributed. Within our city, we have more than enough ophthalmologists, but you go to some rural areas of the United States, and not only are there not ophthalmologists, there's also not optometrists in many places. And so that can be very important as well. And finally, what makes eye care different is that in the United States and in some other countries around the world, it's reimbursed differently. We have an entire separate vision plan in the United States for coverage. And I was on a working group with our National Academies of Science, Engineering, and Medicine where we talked about myopia. And we focused on the fact that myopia is, in fact, a disorder of the eye. It could be thought of as a medical condition, and yet we treat it as something entirely different that's managed differently by a different set of providers under a different payment plan than many other things in the United States. So that's why we need to pay particular attention to cost effectiveness tools when it comes to eye care. There are many different types of cost analyses. You can have a simple analysis of costs. You can have a cost minimization analysis, cost consequence, cost effectiveness, which is what the title of today's talk was, cost utility, which is a very particular form of cost effectiveness, and then cost benefit. And I'll talk about each of these briefly. So when we talk about cost, we talk about prices and we talk about quantities. Quantities can be measured in many different ways. Quantities can be measured using claims data from a national healthcare system. We have Medicare in the United States for older adults. We have Medicaid for individuals in worse economic status. We have private insurance for many individuals. And there's both insurance records and electronic health records in terms of claims and records within hospitals and physician systems. Then there's the price. Are we interested in the price that the healthcare system has to pay? Are we interested in the price that individuals have to pay? Are we interested in the price to the hospital to provide the services? Are we interested in the societal price? And so even when it comes to something as simple as cost and thinking about prices and quantities, thinking about the best way to measure those quantities, and thinking about the most appropriate way to measure prices depending on whose perspective we are interested in, those are both very important things. And when you're constructing a study or when you're reading a study in the literature, understanding what perspective is being taken, society, the health system, the patient, even the employer in the United States is a very important perspective. as well as understanding the time frame and other elements of the data are very important. So that's a cost study. It literally just describes the costs. When we think about the next type of study, cost over time. Okay? When we think about cost over time, if I'm going to publish a study in 2026 and we gathered the data in 2021, we're going to be interested in not publishing what it cost in 2021, because today's decision makers don't really care what it cost in 2021. Today's decision makers want to know what it's going to cost today. And if it's a program like my colleague, Dr. Megan Collins, a pediatric ophthalmologist here at Johns Hopkins, ran looking at going around Baltimore City to screen public school children in the different schools around the city. The price of gasoline, for example, is very different in 2026 than it was in 2021. And so we want to make sure we adjust for inflation. Okay? And there are systematic ways of doing that. We also are interested in if we do something now to prevent a bad outcome much later in life. I'm working with colleagues on a study about encouraging people to buy vegetables with lutein and zeaxanthin to prevent age-related, or at least to try to slow down things like age-related macular degeneration later in life. Well, that's a behavior now that for most people is going to change health outcomes 10 years in the future, 20 years in the future. And so we have to say, saving that dollar 20 years in the future, is that worth the same as today, or less than today, or more than today? As an economist, I'm taught to treat it as being worth less than today. And discounting is a systematic way. If we were in an accounting class, we would call it a net present value. And what we do is we say, for each year in the future, it counts a little less. It's a very systematic way of doing that, but that lets us, rather than just looking at cash flow, spending now and savings later, we can say for each dollar spent now, how many dollars would we have to save 10 years down the line, 20 years down the line, even 30 or 40 years down the line to offset $1 of spending now? So these are important things to think about and look at when you read in the literature. Some other cost issues, I already mentioned this idea of perspective. Whose cost are we interested in? And while a lot of the gold standards suggest we should be thinking about society's perspective, which from a pure economic theory point of view, and I am an economist by training after all, makes a lot of sense and makes it easy to compare one study with another if we all use the same perspective. When it comes right down to it, not many decision makers, government doesn't always use a societal perspective. Patients don't use the societal perspective. Patients want to know, what is it going to cost to me or my family? And so these are things to think about. And then obviously, if we have a study, when we were looking at studies on myopia, many of the studies for cost effectiveness have been done in countries in Asia. And we had to say, well, what does that tell us about myopia prevention and control cost effectiveness in the United States? And so we have to convert currencies from one country to another. Other things to be aware of when you are reading the literature or borrowing results in the literature to make decisions in your own framework. Cost minimization. We'll actually see one of the two studies that we'll look, one of the three studies that I'll look at as examples at the end is exactly this. Outcomes are the same between two alternatives or even more than two alternatives sometimes. And the key is, what do we mean by the same? Do they have to be exactly the same? Do they have to just be not statistically significantly different? And that's actually the most common thing that we mean when it's not the same. Does it have to be the same in all aspects? I'm working with Dr. John Kempen on a study looking at trichiasis surgery in Ethiopia. And, we have two things going on. We have visual acuity after the trichiasis surgery, and we have pain. Now, if it's the same visual acuity but different pain, is that still the same result? Is that still the same impact? Or do we need it to be the same in visual acuity and pain after the study for the two methods that were being compared? And then maybe sometimes it just meets a common threshold. In the United States, we often have these, healthy people 2020 or now 2030, and someday I'm sure we'll have healthy people 2040 goals. And when we get to that threshold, is it just good enough that the alternative reaches the threshold? Or are we truly interested in how much above the threshold it gets? And then the simple question for cost minimization is which one costs less, or if there's more than two, which one costs the least? But one thing that that doesn't capture is whether or not the distribution of the benefits matters. Maybe the average is the same, and maybe one costs less. But if the distribution is different, does it affect the entire population equally? Are the better off economically getting more health from it? Are the worse off economically getting more health from it? Maybe that's what we would be aiming for. But we've got to make a choice as to whether it's just the average of the benefits that matters or the distribution. And again, hopefully in whatever we're reading, when we're reading a study, the authors will tell us how they considered such things. Cost consequence study. So for the costs, we're going to describe them. For the consequences, we're just going to list them. And so thinking about, again, Dr. Kempen's study about trichiasis surgery, we could list out, here's the visual acuity. Here's how the patients respond on a dry eye scale. Here's how the patients respond on an eye pain scale. Here's their ability to get around, and just list out the consequences. And the decision then, it's left to the policymaker. The policymaker themselves, or the physician himself or herself, gets to weigh the different outcomes and compare cost versus outcomes. And the distribution is really just part of the consequences. Hopefully, when we're describing the consequences, we're describing the distribution of outcomes across our population. But again, easy for the decision maker to understand what the researcher is telling them. Challenging for the decision maker to say, how do I compare these things? How do I weight one versus another when I'm trying to decide which of these cost and effectiveness alternatives is better? In cost effectiveness, again, for costs, we're going to describe them. For consequences, for a cost effectiveness study, we need to have just one outcome that we focus on. And we're going to talk about how much extra money we need to spend in whatever currency we're thinking about. I will probably say US dollars more than anything else, just given where I come from, but any currency. And we're going to talk about the extra dollars we need to spend in order to get an extra outcome. Now, that's a nice number for the decision maker to think about. What it doesn't tell the decision maker is, well, how much should it be worth? If we prevent a case of blindness, what should we be willing to spend for that? And should we be willing to spend something different for that in Maryland versus Texas within the United States? Should we be willing to spend something different on that between the United States and Namibia and Singapore and New Zealand? That's something decision makers have to grapple with. And I, as an economist, it's not my job to tell them that. It's my job to give them the data, and they can make the decision on whether or not they're going to spend different amounts in different places within a country or around the world. And for distribution, it's really hard to capture the distribution in that average or that overall impact that I was talking about when we're going to characterize how to make a decision. What we can do, though, is we can do sensitivity analyses by subgroup. We can look at different age groups. Many times when it comes to vision screening, we'll look at what happens if we screen 5-year-olds and what happens if we screen 10-year-olds for myopia, for example, and how much is missed if we waited 5 years between screenings. You can also look at men and women. You could look at race or ethnicity. There's many different categories that we could look at for distribution. When we do these analyses, and I added it for cost effectiveness analysis, but you could do sensitivity analyses even for any of the cost or cost minimization or cost consequence. It's like a what if analysis. If we were thinking of like a business model, we have a basic set of assumptions that we're making for our main model, but we're also going to ask questions like, well, what if those assumptions are not exactly correct? And how do we think about extra things that could go on? And what we want to do is we want to be able to assess the sensitivity of the main conclusion to changes in the assumptions that we make. Okay? And sometimes we change one variable at a time, saying, well, here's the average for the effectiveness of a new way of screening, and we estimated the top and bottom of a 95% confidence interval, so we'll plug those in. And sometimes we change one variable at a time and we say which variable is the conclusion most sensitive to, and that can form a tornado diagram to tell you which one is least sensitive to at the top and most sensitive to at the bottom, or vice versa. We can change all the variables at once and say what would make it as favorable as possible for our new intervention and what would make it the least favorable possible for our new intervention. And sometimes you'll see what are called probabilistic sensitivity analyses. And that's where we have distributions of different variables in the analysis. And with the computer technology we have these days, and in programs like R or just about any statistical package these days, you can simulate different variables and say, we're going to do 10,000 or 100,000 iterations. And in each iteration, here's a distribution of the variables for 5 different variables in the model, 10 different variables in the model, whatever it might be. And we're going to draw randomly from that distribution. And we're going to repeat that 10,000 or 100,000 times. It's quite easy to do 100,000 analyses given today's computer technology. And then look at the distribution of the results. And you'll see that in many studies. I've mentioned already these determinants. So we determine where the values are, one variable at a time, and multiple variables, best and worst case, threshold, and probabilistic. So that's just, again, reiterating what I mentioned in terms of the different types of analyses. Now, before I move on to cost utility analysis, I want to introduce graphical concepts to help us understand what quality adjusted life years and disability adjusted life years are measuring. If we think about some measure of health on the vertical axis and some measure of time on the horizontal axis, then the green line might be a person, somewhat healthy at the start of life, gets a little healthier, never reaches perfect health, sort of has some ups and downs throughout life, and eventually life has ended. And the health experienced helps us to understand quality adjusted life years. And we'll talk a little bit more about that in a moment. The health that we don't experience but could have at every point in time, and then extra years of life at the end out to what the maximum life expectancy would be, that is a concept that gets at disability adjusted life years, or DALYs, which we see in the literature. And we can talk about then, when we talk about cost utility analysis, how much we have to spend to gain more quality adjusted life years, or how much do we have to spend to avoid accumulating disability adjusted life years. So you'll see dollars or other monetary units spent per disability adjusted life year avoided or averted in the literature. So a little bit more about these concepts. Qualities are based on health utility. It's a particular measure of health-related quality of life over time. And on this scale, full health is given a value of 1, death is given a value of 0, and there are some people who think that some health states are worse than death. I know in the United States, we have a debate about assisted suicide. And in that debate, some people do think the health states are worse than death. Otherwise, there wouldn't be a demand for assisted suicide. I'm not saying each of us as individuals has to believe that there are health states worse than death. But when we survey society as a whole, there are some things people think coma for the rest of one's life might be a health state worse than death, for example, in most countries. And so that's just something to be aware of. And you can still be worse than death, but be better off than you would have otherwise. And then the trade-offs that people make when we think about assessing how to measure health utility, we're always interested in people making trade-offs because that's what economists like to study, is how people make trade-offs. But the trade-offs that I would think about for a health state in the United States might be different than the trade-offs that my British colleagues think about, might be different than trade-offs that colleagues in Singapore or China or New Zealand think about as well. And so qualities are usually assessed at a country-specific level. Disability adjusted life years are designed to be equal across countries. That was a whole idea when they were developed in the 1990s. And they were supposed to represent a basic inability to perform human functions outside of any cultural or social context. 0 is no disability and 1 is death. So it's the opposite scale, which makes it confusing for a lot of people, but it does at least, tell you why we're trying to avoid DALYs and why we're trying to gain qualities. Because in the one case, 1 is death, and in the other case, 1 is perfect health. So in a health utility assessment, again, the score for the utility is based on trade-offs. And anytime you see a health utility, somebody somewhere along the line in that study or in a previous study, if we use mappings from previous studies, had to answer a question about their willingness to accept a risk in a trade-off of, you could be cured of this condition, or you have a risk of death or or perfect health if you're or death or either the condition in general, or you have you can be cured right away, or if you're not cured, you will die. And what risk of death are you willing to accept? That's a hard question for many people to grapple with. We could also say you could have this condition for the remainder of your life, or you could be perfectly healthy for the remainder of your life. And would you be willing to give up some of your life expectancy for that? That's a different way of framing it. People find that a much easier question to answer, but some type of question like that was used somewhere along the line to gain data to develop a scoring system for quality adjusted life years. And then a visual analog score, and some instruments just will say on a scale of 0 to 100, how would you describe your health-related quality of life today? And we can ask that, but that visual analog scale does not involve a trade-off. It involves you conceptualizing where you are on the scale, but it's not the same as a trade-off. So economists are very particular that every type of valuation process for health utility should involve a trade-off. And then there are some instruments, the Euroqual 5D, 5D being for 5 dimensions. And there's been a 3-level version where in each dimension it was simply, I have no problem, I have a little bit of a problem, I have a big problem. And now there's a 5-level version that gets you a little bit more specificity for each of the dimensions. The key is there's not a vision specific question. In the 5 dimensions, they talk about mobility, pain, anxiety or depressive symptoms, usual activities, and self-care. And the self-care being things like being able to get oneself out of bed or to the restroom by oneself. Well, there are some things that poor vision could impact. It could impact my mobility. In the trichiasis study, certainly patients have pain before the trichiasis surgery. Um, it could also impact, let's see, so we've got mobility. It could cause anxiety if I were visually impaired. And maybe it would affect my usual activities. Although, again, in some countries, we can accommodate people with visual impairments quite well, and hopefully it doesn't affect their usual activities very much. But there's nothing distinctive about vision in that instrument. The SF6D is a variation of the SF36, a very common health-related quality of life instrument used here in the United States, but turned into scoring using health utility rather than other types of metrics. And then vision-specific questions, the health utility index. The nice thing about the Euroqual is it's available for free. The health utility index is not, but the health utility index does have a vision specific question. I can see just fine without glasses or contacts. I can see just fine with glasses or contacts, and then varying degrees of difficulty seeing even with glasses or contacts, and then legally blind, and also the quality of well-being. So those are likely to be a little more sensitive to changes in vision. And but the most common, easiest one to use is the Euroqual. So it's just interesting again you'll see different ones out there. So in a cost utility study, we describe the cost just like in all the rest of the studies that I've talked about thus far. We measure consequences using this health-related quality of life or health utility measure over time. And you saw the idea of measuring it over time and really thinking about it as an area under the curve type of measure for the quality adjusted life years. And then we describe the extra money needed to gain a quality or avert a dolly, and the regulator or decision maker decides whether it's a good buy. Now, in countries like the UK, they say we are willing to spend 30,000 British pounds per quality adjusted life year gained. And that's actually regulated. Now, you can spend more than that, but you have to justify it. In the United States, we've talked about 50,000 US dollars per quality adjusted life year or 100,000 US dollars per quality adjusted life year for decades. But nowhere in our federal government or our state government decision making is it written down as a regulation. That's what we should do. So we just sort of think about that. And the distribution, normally we treat it that all qualities are equal. So my parents are 79 years old. I'm 56. My oldest is 30, and his daughter is 7 months old. Whether my granddaughter gains equality, I gain equality, or my parents gain equality, it all counts the same. Do we want that to be the case? I would like to think my granddaughter deserves equality improvement more than I do, and I love my parents, but probably more than my parents do. And there are ways that people have begun to conceptualize that, but the standard analysis, the quality counts the same no matter who's gaining it. And that's important to recognize when we think about the values behind our decision making. Incremental analysis, this is just showing as you have higher costs on the vertical axis and higher outcomes or health utility or quality adjusted life years on the horizontal axis. We could compare A and B. B has higher cost but better outcomes. D, you'll notice, has higher cost but worse outcomes than B. So that's what's called dominated. We wouldn't want to choose that economically, although again, with distribution, we might think about it. And C is interesting because it's higher outcomes and cost than A and lower outcomes and cost than B. But if we could figure out some combination of A and B, that would dominate C. So when you see some cost effectiveness studies, they'll talk about strongly dominated and weakly dominated. And again, strongly dominated simply means that one alternative gives you more health for a lower cost. And weakly dominated is this combination type of concept. Again, something that I could spend an entire lecture explaining, but just to be aware of when you read the literature. And finally, cost benefit. We place a dollar value or a monetary value more generally on all outcomes. So I would place a monetary value on my ability to see better after cataract surgery. I could place a monetary value on never needing a pair of glasses, hopefully, for distance vision again after cataract surgery, although I might still need readers. I could place a monetary value on my ability to work. I could place a monetary value on my ability to contribute to my family. I could place a monetary value on not needing care from another adult or child for me if I couldn't get around by myself. And certainly when we think about studies in lower and middle income countries, we often think about these things. Again, distribution, again, just sort of part of the background that we have to think about and consider when we are using this type of information. Now, you might ask, where does the ethics come in? Okay, and when I give these lectures to students here in the United States, they're often like, is there room for ethics alongside economics? And as someone who teaches multiple sections each year of a course called Business Leadership and Human Values, even as an economist, I can tell you there is room for ethics, but we have to be very clear. Okay. And so question number one, should everyone's outcomes count the same? I mentioned that that's our standard form of analysis, a very utilitarian approach. My outcomes, Mr. Gates's outcomes, Mr. Musk's outcomes, and the outcomes of the homeless person I see on the street as I walk in the neighborhood near my office. They would all count the same, but should they? How do we value time gained? Do we value it based on what I could earn? Do we value it based on what I earned before I was impaired, if I have a new impairment? If you value it based on specifically what I would earn, how do we then say that my time is worth more than my administrative assistant's time? Is that fair? Should we vary it by gender, which historically we have in the United States, interestingly enough, and is that appropriate? Should we vary it by age? Again, all these questions that don't always get re-asked for every study, but somewhere in the study, people are making assumptions about how we're going to value these. How do we value a life saved? Okay, if that person who avoids becoming blind avoids a fall and avoids all the complications of the fall, which particularly if it's an older adult who becomes blind, that could be something very critical for an older adult's health. How are we going to place a dollar value? And is it valued the same or is it valued less because it's an older adult compared to a young child, for example? Should different countries have different thresholds? We often see you should spend less than 3 times your GDP per capita to gain equality or to avoid a disability adjusted life year, but that means we're willing to spend more in the United States than we are in Senegal. And then what level of certainty do we require to make a decision when we have all those what if analyses that I mentioned earlier? If some of them indicate, well, it might not be quite as good a buy as we think, well, do we have to be 20% certain? Hopefully at least 50% certain, but then do we have to be 70% certain? 95% certain? There's no one rule as to what to do with that. So 3 quick examples. One, a study that I was involved with, refractive error correction and harvest worker productivity. This was looking at coffee bean sorting productivity in Guatemala. And what was amazing, well, actually not amazing, because certainly there had been studies done for garment workers in Bangladesh and tea pickers in India showing that, yes, there's measurable change in productivity when you give those workers glasses. And one of these days we'll figure out how to measure this well in a higher income country. But I know for me, how do you measure my productivity as a professor? It's not nearly as easy to measure my productivity as a professor as the coffee bean sorter or the garment producer. Anyway, we found a 7.9% increase in productivity among coffee bean sorters when we gave them glasses. For each case identified, it cost $13.40. Now, we're screening multiple people to identify one case, so it's a very inexpensive screening process if we're only spending $13.40 for each case identified, and then $16 for glasses. Certainly, these glasses that I'm wearing cost a lot more than $16. But even in the United States, there is good data that we could produce certainly a pair of readers for about $5. I can get those at my drugstore or grocery store here in the United States. And then we could look at production in other places around the world. And $16 is a reasonable amount to spend for glasses. So the workers gain 12.2 pounds per day. And if we value it at just under 12 cents a pound or $1.40 per day of gain, and there's a 75-day growing season, that's $107. So that individual could pay for the glasses and still gain. Now, do you have them pay for the glasses up front? Do you have them work and pay for the glasses at the end? Even the farm owners could afford to run this whole program, pay for the glasses for their workers, maybe keep the glasses on the farm through the season, and then give the glasses to the workers at the end. So this is where it's not just economic evaluation like a cost effectiveness study, but really thinking of unique and creative business models to make it make sense for the farmer as well as for their workers so that their workers can feel like they've gained. And that's where the business side of things, I mean, I used to sit in the School of Public Health, and I've been at the business school now for 13 years and thinking about new and creative and innovative business models and ways to make this make sense for the farmers and the workers can encourage the adoption of new technologies and bringing something as simple as reading glasses and distance spectacles to people in countries where they're not as prominent right now. A second example, also by my colleague Brad Wong at Metalytics and his colleague Bryce Everett and myself and several other studies, looking at cataract and uncorrected refractive error and looking at things like school screening, door-to-door, eye camps, and vision centers. And for each of these, looking at, as you can see, total costs, disability adjusted life years avoided, and then we talk about incremental costs, incremental disability adjusted life years, and then this idea of the extra money that we're spending, the incremental cost for each disability adjusted life year that we avoid. And this table captures this concept. As we move down the chart, it's always more expensive, and there are always more disability adjusted life years averted. But sometimes there is this concept of weak domination. So what that says is some combination of not doing much of anything in eye camps would be better than school screening or door to door. But the vision centers are are enough better than eye camps, and both in terms of how much they cost and the disability adjusted life years avoided, that it still only costs a little over $260 US per disability adjusted life year avoided, and that would be a good buy just about anywhere in the world by the standards of thinking about GDP per capita as a relevant comparison. And then the last example is a decision tree. This is a study in Singapore looking at telemedicine diabetic retinopathy screening program. And this has to do with who's evaluating the results. And so there's only supposed to be one slide with the decision tree. We can represent the decision tree to show how things happen. We can represent, this is a fancy way of representing the decision tree, that people start with no diabetic retinopathy, then have mild diabetic retinopathy, moderate to severe. They can go blind. Their diabetic retinopathy can be stable. At some point, individuals will die, and you're simulating this over time. And you're working with a population and say, we're going to screen. How often are we going to screen? And who's going to evaluate the results? Is it going to be a family physician? Could be an ophthalmologist, could be others. And so this shows, with the new program versus a family practitioner model, we get similar levels of quality adjusted life years gained in both cases. And yet the family practitioner model cost more. And so if it costs more but gives you the same outcome, unless there's something fundamental about the distribution that would make us be interested in spending a little more money, from a purely economic point of view, we would say, no, no, we don't want to spend more to get the same outcome. So we will now have some time for Q&A, but let me just conclude by one simple thought, and I'll stop sharing as well to have a discussion. Um, when we think about any of these types of analyses, cost effectiveness, the cost minimization, what I hope you take away from this is the tools are important to understand. We can use data from the past and bring it into the present. We can look ahead to the future and have a systematic way of comparing costs now with impacts later. Every time we make a decision on how to do this analysis, it reflects our values in some way, shape, or form. It reflects values that we think about for the distribution of outcomes. It reflects whether we're going to choose an instrument that has a direct measure of vision or only the impacts of vision on other things about quality of life. And when we think about that threshold, are we going to make one decision for all parts of our country, for countries that are like big like the United States? Are we going to make one decision for different countries around the world? These are the important things to think about and keep in the back of your mind as you're reading these studies or conducting these studies to help people make the best decisions possible. And with that, we'll open it up for questions.
Thank you very much for that, Kendall. I think that's very good introduction, right? You covered a fair bit of the different instruments that we can use to apply when we look at cost effectiveness. I think you made it easy for the panelists as well as our fellow participants here today on how to understand and analyze as well as critically look at what values to assess when we are looking into the literature. I think with that, we will enter into the Q&A segment. I will encourage participants to either, you know, post your question in the Q&A column, and I will try to pick them up when they're relevant to ask Professor Frick, or you could, I don't know whether it works. Just raise your hand and then open your mic to ask your question. But what I'll do is I'll kickstart the first question to Professor Freak and as well as to Dr. Loon for us to open for us to warm up to this Q&A segment. Kendall, and Xingji, I think in general. I find it difficult to borrow evidence from other country and apply it directly to the local context. And those challenges can come in many forms apart from currency. It is also about policy. It is also about the nuances in terms of remuneration and who pays for each of these component as well. And perhaps more importantly as well, Singapore being a small country, the volume of how we consume a particular intervention, for example, or the behavior is also ultimately different from bigger countries, like say in the States or in India or in China. So maybe my question is to the both of you. When we borrow information or data, where are the key aspects that we need to identify and maybe make some adjustment so that it becomes relevant to the local context?
That's a great question. And I think I would begin with thinking about, how much does the person who reports the study that you're trying to borrow from, how much did they sort of break it down into what we might think of as the ingredients of the cost, as opposed to just giving you a total cost? Maybe they told you how much ophthalmologist time is needed. Maybe they told us how much optometrist time is needed, how much time is needed from a support person, and things like that. And maybe they reported separately travel. So certainly, the amount of time that it takes for an optometrist or an ophthalmologist could easily be the same from one country to another to do the clinical part. What's going to be different is things like rent on locations. What's going to be different is things like travel times, particularly if you're looking at something that's statewide in the United States or national in the United States. And so, to the degree that our colleagues who are publishing give us that ingredients-based approach to assessing costs. We can pick out which ingredients are most useful to us and convert the currency and figure out what our own wage rates and compensation rates are while borrowing the quantities. And I think sometimes that's the most important thing that we can borrow from other studies.
Just to add on that, when I was doing my health economics lectures, I took my health economics in Sydney Uni previously. So some of the things you might want to use are some of the basic markers that are found in general diseases, diabetes, TB screening, pap smears. Many papers have been written in many countries on this. If you use them as a warm-up, that it helps you to understand some of the information that's been coming. So for somebody who may not have taken an actual course in health economics, these will get you into the idea of reading off qualies and so forth. And then you start thinking about the in terms of the cost. For example, in Australia, it was about $25,000 back then. And I believe you mentioned about £30,000 in UK. So it's contextual and also relevant to each economy. For example, $25,000 might be a huge amount in Senegal and so forth. But the basic principles are very similar, and it gives you a warm up when you think about these. And there are many well written papers, for example, on diabetes. So those will give you an idea. Diabetic screening, diabetic retinopathy screening will then edge you one step closer to the ophthalmic aspect of it, and then some of the finer diseases. So these major diseases have been very well documented in many papers, and many of the health economics students would have begun cutting their teeth on some of these first before they write their own papers and theses on this as they move along. Thank you.
Yep. I would just move on to the second question. Maybe Kendall, you could take this question. You know how AI is now becoming artificial intelligence is now becoming commonplace, and in Singapore we do put quite a bit of emphasis on the use of AI and automation to help us with our work. From your perspective, um, are there any particular changes or any advice on how do we evaluate such AI augmented diagnostic systems?
That's a great question. I know I'm working with Dr. David Friedman at the Massachusetts Eye and Ear Institute, where Dr. Friedman is already using what's available readily in the United States, screening for diabetic retinopathy using AI. What he's trying to add is looking at the same photograph and not diagnosing glaucoma in the same way that AI is now approved to diagnose diabetic retinopathy, but to at least use it to do a selective screening for glaucoma and know who needs to be screened more using the same photograph. Now that's great. Now the interesting thing is, on the one hand, it doesn't seem to add any cost. But you have to develop it first. So thinking about it from one step back, if it hasn't been developed yet, how much are we willing to spend to develop it? I know my colleagues who think about environmental sustainability, we haven't figured out an easy way to put that in the calculation of cost effectiveness for AI yet. But given what we know about the carbon footprint of artificial intelligence, somehow or other that has to be thought about. Again, there is no standard for putting that in. The hope is obviously that with that, the throughput for the individual optometrist, ophthalmologist, whoever is using that AI system can be enhanced quite a bit, because the AI can take away the time that's necessary for the clinician to make that assessment, and the clinician then can do the other steps that are necessary to care for the patient. Or when we think about scope of practice, we might be able to have that first step taken by someone at a lower scope of practice before getting to the ophthalmologist who has the widest scope of practice of all the practitioners. So AI can make a very big difference. I think the key is really thinking about the way it then impacts workforce, the way it impacts economic opportunity, and the cost of development. So analyzing the particular clinical application of AI, we really approach just like anything else. Analyzing the much bigger picture of what AI means to society and the economy, there are other things that ideally we would at least be aware of and cognizant of when we're doing those types of analyses.
I think you brought up a very a good point, Kendall. So I thought I'll add on to that. perspective as well. There are other things which we have to consider when it comes to cost, right? And to me, there are quite a number of hidden costs. You mentioned about the development of an algorithm. Actually, that's also cost, right? Time has been put into that. And I'm also aware that there are regulatory hurdles as well. You know, you go through trials like this, you will have to put in safeguards, guardrails, and all this add-on costs, which otherwise would not be required for a traditional diagnostic system. So that is one. And second thing which I thought would be appropriate and important is to look at the implementation of such a system. When the implementation or the adoption is not at 100%, maybe I would like to ask you, is there any way to factor in the the implementation of a system, right? Are we making an assumption it's going to be 100% adopted? You know, how do we also factor in maybe false negatives, right? Or maybe about people who don't want to use this and end up having to do multiple different tests just to get to the same outcome.
No, it's a great question. So I'll start with the less than 100% adoption. Um, Budget impact models are ones where this often becomes quite important. Now, budget impact models are most commonly done in the pharma space. You know, we know what the current distribution of the use of different pharmaceutical products is, and a new product is on the market. And so, what is the likely market share of that new product compared to what's already in the market? And how are we changing? How does that change the cost? And how does it change the outcomes? Okay, so that's a simple way of doing it. We don't often think of market share or market penetration for new technologies in the same way that we would think about it for pharmaceutical products, but we can. And we can ask, okay, if this is adopted by 10% of the providers, 50% of the providers, 90% of the providers, and that's where a healthy dose of thinking about it as implementation science, in addition to the pure cost effectiveness and randomized trials, becomes important because the implementation science really forces us to drill down and ask questions like, all right, well, what will be the adoption rate of these things? And that's quite important to think about. When we think about, the multiple tests, that's where something like a decision tree becomes very important. And that's where, for example, with Dr. Friedman's work, um, when we think about, the same photograph that's used for diabetic retinopathy, and now using that photograph to help decide whether we're going to screen for glaucoma, well, we need to know if we're going to model that without doing the whole rest of the study about the screening and whatnot, what is the sensitivity and specificity or positive and negative predictive value, depending on how you're running the model of that screening with AI, and then making sure to build in, oh, well, there would have been one test earlier, and now there's two, or there's all these different steps. And the interaction between those either has to be designed into the study that you're doing, or when we build these decision trees and Markov models, as I showed in the last of the three examples, that's a place where you can include this type of information.
Great. Thanks, Kendall. So maybe we'll move to the next question as well. This is probably very relevant as well. You did mention about the general EQ5D, right? These are utility values, instruments that kind of act as a proxy for vision-related questions. So, is there any opportunity to develop maybe a more eye specific, right, ophthalmology specific, ophthalmic specific utility values? And are there plans to do that? And would that be a bit more accurate? Do you see the value in that?
So one thing that people have done is to look at and the EQ5D, people have used it, but again, the challenge is whether it's going to be very sensitive in terms of how the visual acuity shows up as a main question. What's interesting though is that increasingly two things are happening. One, Gary and Melissa Brown here in the United States have done a lot of work trying to look at the health utilities related specifically to vision. And the biggest challenge that we have there is it just a vision utility scale or is it a health utility scale? And people have debated that back and forth about the Browns work, but the Browns have made a good contribution, even if it is a vision specific utility. one other thing that people have done using things like the NEI-VFQ, the Visual Function Questionnaire, from our National Eye Institute here in the United States. If you've got NEI-VFQ data and you've got data from one of the more sensitive health utility instruments, you can then run a regression analysis between the two of those. And you can say, when we have this type of change in the NEI-VFQ, here's what it predicts as a change in whatever health utility instrument. And so it's not that we developed an instrument specific for the utility of vision, but by measuring a health utility instrument that is sensitive and a visual function or other vision specific questionnaire, we can then map between the two. And there's been a good bit of work on that over the years here in the United States and around the world.
Mm. Kendall, I think you kind of mentioned this during your talk, and this is related to the question that I'm going to ask next from the participants. There is a big range of socioeconomic status, right? Some people who have on a higher range and those who are maybe less privileged and on a lower socioeconomic range. And surely any intervention that we are looking at when it comes to cost effectiveness analysis is going to be a difference between those on each spectrum. But unfortunately, and I think it's probably true, those on the lower end of the socioeconomic status tend to not fare as well, right? So, in theory, if you average this and present something theoretical, it may not fully represent the real life, right? Real world behavior. And how do you account for that so that more light can be shown on those on the lower socioeconomic status where they're more vulnerable?
So, one thing that, again, some of my colleagues in the international space in particular are working on are sort of what they call distribution informed cost effectiveness analyses. And really thinking about, again, this question of whether it's by age, and again, what I raised in my parents, myself, my child, and my grandchild, or by socioeconomic status. Like, are the people who are making what I'm fortunate to be making as a full professor at a private university in the United States, are we going to give precedent to my health? Or are we going to give precedent to the people who are at the low end? And there are definitely ethical structures where there are ways of differentially weighting. What we haven't figured out is how to easily incorporate that into our analysis rather than just describing it. And what we would often do, is we would look at, okay, well, let's look this is part of the sensitivity analysis by subgroup. Can I ask, is this intervention going to make more of a difference for the low income individuals than it does for me? Is it going to make the same difference? Or maybe it is one that for whatever reason works great for me, but doesn't work particularly well for low income individuals. If it comes to transportation to healthcare, some places in the United States, there's all kinds of times when low income individuals need a lot of help that they're not able to get unless you build it into the analysis and the intervention. And so I think the key is to be aware, increasingly trying to figure out ways to include it, but thinking very hard so that it's not lost in the shuffle and we don't just make decisions based on averages when the distribution is very important.
Thank you so much for that comment. And really, we have benefited a lot from your experience as well as how you look at various challenges that we have when it comes to cost effectiveness analysis. I think really we don't have we're coming to the end to this webinar. There are still quite a number of questions that are unanswered in the Q&A, but like all good things, it comes to an end. We don't have time to answer all those questions. I just want to say a very big thank you, Professor Kendall, for your valuable time in presenting this the talk for us. At the same time, answering questions that are a bit more specific and Asian centric here in this part of the world. I just want to end off by sharing that the next webinar, that's right, I think we are showing it on the screen now. We are going to feature Professor Johannes van der Stern, and he'll be hosted by Professor Raymond Naja in his talk, Visual Information Processing stability and flexibility. So do look out for that date. Book your time, and also hope to see you in the next webinar. With that, Professor Kendall, Dr. Loon, thank you very much for your time, and I hope that we have an opportunity to see each other and work with each other again in future.
Thank you very much.
Thank you.